Hello. Hello. Yes. हाँ ठीक है. I will come at 8 o'clock, 7 o'clock on the question about. Yeah. Oh.
Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Ratan Jha. Sir is senior nephrologist and transplant physician at Care Hospital Outpatient Center, Banjara Hill, Hyderabad. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is lupus flare. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Good evening, friends. It's a pleasure for me to talk on a very interesting topic, which is highly complicated. That is lupus flare. It is my area of special interest, and hence I have accepted to talk on this topic in a lucid manner so that it will be of use to those who are listening to this presentation. The talk is on lupus flare is going to go through the following heads. We will introduce the topic, the why we are talking about lupus flare, how do we define lupus flare, what is the burden of this flare or the prevalence of flare in the context of SLE, what are the causes which are incriminated to be responsible for flare, do we have any biomarkers to make a diagnosis of flare, how should we approach this problem, what are the treatment, what are the preventive approaches, and what is the outcome. We know that SLE is a disease of remission and relapses, and it colloquially is referred to as lupus. The term lupus means looking like wolf, because many of the patients of SLE, because of their facial rash, they look a bit different, and hence the term lupus has come. So lupus or SLE is the same disease, spoken in different context. And when we talk about lupus flare or relapse, it means the same thing. The term relapse is always used in the context of remission, that after the whole thing has shown a complete kind of remission, and then it comes back, it is called relapse. And in absence of complete remission, the things, if it gets worsened or exacerbated, it's called flare. So for all practical purposes, lupus flare or lupus relapse will mean the same thing. And we are going to discuss this problem in the subsequent slides. We are all aware of the fact that SLE or lupus is a very complex multi-system disease, which is not an uncommon autoimmune disease. It affects nearly 1 in 1,000 the people, at least in UK, where the data are available. And the reported prevalence of this disease in US is said to be 15 to 50 per 1 lakh patient. So it is not an uncommon disease, and in any busy center we see such patients quite often. Despite the improvement in survival over the last 40 years with better understanding of this autoimmune disease, lupus patients still die younger, and the life is cut on average by 25 years compared to those who are having no disease if they are male or females in UK. So it reduces the lifespan by roughly 25 years despite modern advances in the treatment. And hence, we need to understand this disease better. This disease is punctuated by flares or disease exacerbation of various severity, as we see in other forms of autoimmune diseases like multiple sclerosis and many other diseases where the disease comes and goes. Flares in SLE patients incur significant clinical financial burden in our country and needs an exclusion of the SLE lupus flare mimetics, because many times infection mimics as a lupus flare, and it has to be always kept in mind before we try to increase the immune drugs increment for taking care of this, because whenever we find a lupus flare, we always go for increasing this anti-immune kind of approaches that is there. The definition of lupus flare has been given in 2011 by the Lupus Foundation of America, which defined a flare in lupus patient as a measurable increase in disease activity in one or more organs involving uh, new or worse clinical signs and symptoms or lab measurements. So there has to be a measurable increase in the symptom or sign. It cannot be a vague kind of symptoms which we cannot measure to define lupus flare. The second point is that when we make a diagnosis of lupus flare, it must be considered clinically significant by the treating doctor, and usually there should be at least a consideration of a change or increase in the treatment or immunosuppressive therapy. So these are two things which has to be always included in a definition of lupus flare, that the things should be quantifiable and things should be meaningful to require a change in drug prescription. Diagnosing of lupus flare in SLE could be quite perplexing, because the symptoms and signs are multisystemic in nature, and all the symptoms or signs have low or modest specificity of its manifestation. That is, the same symptoms could be seen in different diseases, and the same symptom may not mean the disease has become active. For example, the pain in the hip joints could be a symptom of disease activity, but it could also be a symptom of chronicity or some kind of complication because of disease therapy. So this is a difficult kind of a problem which has to be properly addressed. So when we're trying to make a diagnosis of lupus flare, we should be able to discriminate these symptoms and signs from other mimicking events like infections, drug adverse events, and fibromyalgia, which is quite common in our day-to-day practice. So this is one of our patients of lupus nephritis who was in the follow-up for more than 10 years and has come on immunosuppressive therapy with new onset seizure. We know that seizure could be a manifestation of CNS lupus, but that was not the case in this patient. What we see is in the CT scan and in the MRI of the brain, that there are 3 rings which are seen in the brain parenchyma. It were all tuberculoma of the brain, which was mimicking like a disease activity in a patient who was being treated for lupus nephritis. So whenever we see a symptom which mimics like lupus flare, we need to always have a differential diagnosis in mind to exclude the other possibilities. This was another patient in the follow-up for lupus nephritis and was having a chronic pain on walking. What we see in the X-ray pelvis is the presence of bilateral avascular necrosis, which, if not thought about, could mean in another context a disease activity, a pain in the joints. But this was a patient who was having a drug toxicity with avascular necrosis, and which requires no enhancement in immunosuppression, but rather reduction in immunosuppression with treatment of the basic problem with other surgical measures like what was done in the patient on the right side of the hip replacement, which takes care of the joint pain in patients of SLE. So the same symptoms may have different meaning, and it has to be always looked in the proper context. The burden of lupus flare is shown in the slide, that after we achieve remission or low disease activity with our immunosuppressive therapy, it has been noted that close to quarter of patients again have a flare or relapse of the symptoms or signs within 1 to 2 years. And close to 50% of patients may have, after achieving remission, a relapse within 5 to 10 years. So the disease has to be followed up, even if the disease has come under control without disease activity, is the message from this slide. It has been noted that almost 75 to 80% of patients who develop flare after remission are having a problem of mild to moderate severity, while the remaining quarter of patients may have a disease flare which could be classified as severe, which we'll discuss in the subsequent slides. So the flare is common. close to 25% happens within 1 to 2 years, and half will happen within 10 years, with 1/4 having severe flare and 3/4 having less severe flare in the follow-up. When we talk about flare, the nature of flare in SLE could be diverse. The most frequent organs in lupus flare or SLE are mucocutaneous, that is, you have increase in the skin rash or other kind of skin manifestation. There could be an increase in the musculoskeletal symptoms, complaint or signs and symptoms. Immunological flare could be in the form of increased this immune dysregulation, manifested as changed titers of ANA, double-stranded DNA, complement C3, C4. Hematological flare in the form of cytopenias, common being thrombocytopenia and hemolytic anemia. But the kidney-related flare is the most frequent organ domain flare, which is seen in close to 30 to 40% of patients in the follow-up. So there could be various organs which can show a kind of flare, which has to be investigated. Most flares are preceded by moderate flare in the same organ or domain. That is, a person who has kidney disease as a basic diagnosis of lupus can have a flare in the same organ in the follow-up. Importantly, up to 20% of severe flares are accompanied by new onset disease or worsening of previously affected major organs such as pleura, pericardium, or kidney and CNS. So the flare could also affect other organs, which could be very severe. For example, a patient who has skin disease or joint disease to begin with can develop a flare in the form of kidney involvement, or heart or lung involvement. So one has to see the combination of signs and symptoms to make an accurate diagnosis of lupus flare. To reiterate the point, most of the flares which happens after the remission are mild to moderate, that is not very severe, which will not require kind of heightened dose of immunosuppression. But 20 to 30% of flares could be very severe, which will require a very aggressive approach to control the disease activity. The next question is who are the patients who are likely to get this kind of flare? It has been reported in literature that flares are more frequent in patients who have a persistent immunological activity, which we refer to as the presence of the high titers of ANA, double-stranded DNA, and low values of complement C3. Persistent clinical activity in the form of the symptoms in different domains continue to be present. For example, the skin rash or the proteinuria or the edema. Flares are more frequent when there is any kind of triggering events which happens. For example, in pregnancy, the flare can come in the peripartum period. And the commonest, one of the reasons of flare that we see in our day-to-day practice is non-compliance or drug default. That patient gets tired of taking the drugs, they stop the drug to get into flare or disease activity. It has been reported that less than 25% of SLE patients have a drug adherence rate of more than 80% of the time. That is, it is quite a common problem. And the non-compliance with lupus treatment has been associated with increased risk of flares in the literature. The other triggering events which have been reported to be linked to the lupus flare are certain environmental factors like exposure to ultraviolet light, that person going to the beaches, getting exposed to sun directly can have a disease activation. Infections like COVID infection have been known to be associated with increased risk of flare. Certain hormones, particularly the oral contraceptive pill, which is used for menstrual regulation, could trigger such kind of flare. And drugs like hydrogen or many other drugs which are associated with cutaneous flare are known to be the triggering factors. And this environmental factors is said to activate the innate as well as adaptive immune system, which ultimately leads to inflammation, cytotoxic effects, and the clinical symptoms. So these are just the triggering factors, but the same immune system dysregulation happens after this triggering event. Disease flare often occurs without apparent cause. That most of the flares that we see in our clinical practice are not having a very clear-cut kind of reason why it has happened. It's perhaps from the progressive inherent build-up of autoimmunity. That is, the immune system is slowly getting more and more worsened over time as for what dysregulation is concerned, and it produces a trigger. So this was a patient that we saw about 1 year back, a patient of lupus nephritis class 5 in total remission with a going for planned pregnancy, the first pregnancy. During the first trimester of pregnancy, the patient had some kind of bleeding per vagina, for which progestogens were prescribed. And following this progestogen therapy, what was seen was a very severe cutaneous flare. The face is showing a classical kind of malar rash, with the hands also showing a rash. So this was a post-oral hormonal therapy during pregnancy, which led to a cutaneous flare, which required higher dose of steroid to control the disease activity, and the patient delivered with a normal child. So this is the follow-up. What we see is that postpartum, the skin rashes are all gone. So one of the causes of flare that we shown was the hormonal therapy, which we give for in female patients for menstrual regulation. But this could be a factor which can trigger it. The other risk factors for disease flare in the patient is actually shown in this slide, that somehow the race is important. The Afro-American race is said to be a factor. Male gender is also said to be a factor. Age of SLE below 25 years, that is younger age, is associated with increased risk of flare. If person has major organ disease like cytopenias, that is thrombocytopenia or leukopenia or hemolytic anemia, they are more risk in the follow-up. Neuropsychiatric lupus, nephritis or lupus nephritis, and vasculitis. If it happens, it can wax and wane. It can come down to go up again in the follow-up. Persistent clinical disease activity, which is immunologically detected, that is low serum C3, C4 and high anti-double-stranded DNA. Even if there is no clinical features of SLE at that point of time, if the immune system is showing an activation, they are at risk for developing a lupus flare in the follow-up. Poor compliance to treatment is already been discussed. That is one of the very important causes of lupus flare in the follow-up. Not using or discontinuing hydroxychloroquine for any reason is known to be associated with increased risk of flare. Quick tapering or withdrawal of maintenance immunosuppressive treatment has been also noted to have increased risk of flare. Serum BRIS level more than 2 nanogram per ml is also known to be associated with flare. So there are many risk factors which are there, and when we are trying to treat a patient, we need to be looking at the clinical signs and symptoms in the context of these risk factors which are present or not present. So the diagnosis of flare in the context of clinical trials are basically based on the either clinical parameters or the lab parameter or combined parameters, and they ultimately look at the increase in disease activity score assessed by a kind of questionnaire which is validated index, or appearance of new symptoms or worsening of the disease manifestation, that is increase in say proteinuria and renal flares. Change in the physician's global assessment, which is simple tool, like we talk about the subjective global assessment in nutritional kind of assessment in a patient of chronic kidney disease. It's a subjective tool which doesn't require any kind of pro forma. We have to look at the patient and make a judgment towards more active disease or severe disease. And the flare, whenever we make a diagnosis, we need to decide which way we are trying to intensify the treatment, whether by increasing the doses of steroid orally, locally, or intravenous. So the reason for defining the flare and try to recognize the flare is that we need to prevent it, etc. It has been noted that flare has been found to be a significant risk factor for development of irreversible end organ damage. Evidences from observational studies have shown that every exacerbation of SLE, the risk of subsequent organ damage assessed by the validated tool has been found to be 2 times. That if a person, say, who has a kidney disease and develops a lupus flare, there is almost a kind of the risk of doubling of the kidney injury by 2 times. Prevention of flare has been recognized as a distinct target in SLE and involves at least use of hydroxychloroquine and maintaining a low level of immunosuppression or biological therapy for several years, and avoiding non-compliance to take care of the end organ damage which will happen in absence of such prevention. So how do we diagnose lupus flare, and how is lupus flare diagnosis different from diagnosing SLE is going to be shown in the subsequent slide. The diagnosis of flare or lupus flare is made clinically after excluding other diseases or infectious diseases which can mimic like lupus activity. Surgical tests such as serum complement and anti-double-stranded DNA are said to be useful, but they lack high diagnostic accuracy in monitoring SLE activity. So though they are useful, but they do not have a high diagnostic accuracy. Approximately 30 to 40% of lupus flare involves at least two domains or organs, that is skin, joint, hematological domain, immunology, or renal, and hence a combination of two organ dysfunction with the autoimmune disease could make the diagnosis of flare much more certain. When we diagnose lupus flare based on the combination of signs and symptoms, we try to categorize the flare into a flare or disease activity mild, moderate, or severe, so as to decide what is the degree of intensification of immunosuppression that is required. Mild disease is usually a disease which is clinically stable with no life-threatening organ involvement and mainly affect the superficial system, that is mainly affect the skin, joints, and maybe mild pleuritis. Patients who are having moderate disease have more serious manifestations, and they may have pericarditis, pleural effusion of a serious nature. Severe disease is defined as organ dysfunction or life-threatening organ involvement in the form of involvement of heart, kidney, and brain, and which will require a kind of more severe immunosuppression. The diagnosis of lupus and diagnosis of lupus flare is almost on the similar lines. When we try to make a diagnosis of lupus, we try to follow certain criteria, like 4 out of 11 criteria as enunciated by the American Rheumatic Association in 1997, or 4 or 17 criteria of SLIC criteria, or the SCORE 10 criteria, which is the latest criteria of that we will discuss in subsequent slide. So it should be, so that is the diagnostic criteria for SLE, and when which should be in association with ANA positivity of above 1 is to 80 or 10 point in the lupus scale. When we find that these things are there but not exactly following 4/11 or 4/17 criteria, it could be considered as undifferentiated syndrome. The flare is a kind of diagnosis of lupus with increased activity in more than one out of the 7 domains that we show in the subsequent slide. The same disease, if it is occurring in more than one domain, it is likely to be a lupus flare, where we have to combine the symptoms and signs based on the criteria, ACR criteria, SLIC criteria, ULR criteria. Lab evidence should be supportive of ANA positivity with higher titers of dsDNA and low titers of low levels of C3, C4. And we may support the diagnosis by either some biopsy evidence of skin or kidney, other radiological evidence of based on the X-ray, CT scan, or MRI to diagnose the characteristic findings of organ dysfunction. So it is basically a kind of combination of sign, symptom, lab, as well as the radiology. So these are the clinical manifestations of active lupus, which is shown in the slide, that when we see a patient who has an active disease, they may have fever, weight loss, musculoskeletal symptoms, cerebral involvement in the form of pleuritis, pericarditis, skin involvement in the form of butterfly rash, hematological involvement in the form of anemia, leukopenia, thrombocytopenia, thrombosis, and kidney involvement in the form of proteinuria, hematuria, renal dysfunction, or any other kind of electrolyte disturbance or severe hypertension. So based on these symptoms, there are various kinds of criteria that have been given in the literature, and we can follow any of the criteria. The earlier criteria was following American College of Rheumatology, where 11 criteria were there, and 4 out of the 11 was set to support the diagnosis of SLE, and the same diagnostic criteria can be utilized to see that whether we are having symptoms of lupus flare. So this is other kind of guidelines where instead of ACR 1977, SLIC criteria 2012 or ULR criteria 2017 can be utilized to decide that the symptoms that we see are fitting with SLE disease activity or SLE flare. So there are 7 domains: the cutaneous domain, the joint, the serositis, renal, neurological, hematological, and constitutional domain, and each of the domains are given certain points to make a diagnosis of both SLE as well as the lupus flare. The definition of lupus flare, according to validated indices, are shown in the slide. We have various kind of indexes, like Physician Global Assessment Index, SLE Disease Activity Index, SFI Index, BILAG, that is British Isles Lupus Activity Scoring System, SLAM and LI. These are all the research tools to make a diagnosis of therapy as well as the follow-up in a patient of disease activity. So we commonly employ the Physician Global Assessment tool because that is easy to do. What we see is that we give a visual kind of assessment based on mild, moderate, and severe. 0 to 1 is mild, 1 to 2 is moderate, and beyond 2 to 3 is severe. Mild means patient has only mostly continuous symptoms in the form of fatigue, malar rash, diffuse alopecia, mouth ulcer, etc. Myalgia. Moderate symptom means patient has, besides fever-like thing, have cutaneous vasculitis, alopecia, pleuritis, pericarditis, and severe means besides that they may have a kind of pericardial tamponade, patient may have acute renal failure or RPGN, or a kind of psychosis or optic neuritis or severe thrombocytopenia. So this is just a quick way for a physician to make a diagnosis of how severe is the flare to decide about the immunological therapy. This is just a slide to show that how this SLE activity is scored in the research methodology. SLED, SLE Disease Activity Index 2000. There, every point that we talked about in the making a diagnosis is given a score, and based on that, we try to see how severe is the disease activity. Similarly, the BILAG score, the British Isles scoring system, which gives a kind of every item a kind of scoring point to make a diagnosis. We should always look at the differential diagnosis, where lupus flare can be mimicked by various entities. Fever is a frequent manifestation of lupus flare, and this could be part of SLE or could be part of infection. Therefore, we need to exclude the possible infection in patients who are receiving immunosuppressive drugs before we decide to give additional immunosuppressive therapy. The presence of objective signs of lupus activity like frank synovitis, involvement of multiple organs, like person has, besides synovitis and skin rash, is having kidney involvement in the proteinuria, hematuria, increases the likelihood of flare or disease exacerbation. So if you have more than 2 organ kind of involvement, it is likely to be a lupus flare in the appropriate context. Lupus flare is often presenting with very non-specific symptoms like hair loss or constant symptoms like weight loss, feeling depressed, muscle pain, which could be mimicked by the drug reaction, by infection, fibromyalgia, anemia, endocrine disorders like hypothyroidism, or occasionally it could be seen to be associated with malignancy in the long term when person has received long-term immunosuppressive therapy. So we have to always look at whether this is a true flare or it is a mimicking flare. This is a patient seen by me for active lupus, presenting with fever, weight loss, edema, and proteinuria and hematuria, was biopsied and was found to have a class 4 lupus, classical kind of diffuse proliferative glomerulonephritis, with some of the glomerulus showing presets. So, but she was having oral ulcers, and despite treatment, though the other things improved, but dysphagia persisted. So this is a patient's immunofluorescence. What we see is that all kinds of immunoglobulins are there. So it is called a full house match. So when we get a full house kind of immune deposits, it is highly characteristic of SLE, though it can be seen in some other situations as well. So this patient who was continuing to have a dysphagia despite getting an immunosuppression for his active disease was found to have, on detailed evaluation, a kind of parapharyngeal abscess collection in the region of mediastinum, which on aspiration showed it to be because of fungal infection. So aspergillus was grown in the culture, as well as on the light microscopy with the appropriate staining, it was filamentous structures were seen. So this was the patient where we had a kind of difficulty in making a diagnosis of disease activity versus a mimicking kind of activity, which was because of infection. The patient was treated, but he succumbed to her infection. The disease became inactive, infection worsened, and patient died. So one has to understand that despite the disease being active, one has to many times decide against giving an immunosuppressive therapy in an appropriate situation. So there are certain biomarkers which have been evaluated to decide whether the person's symptoms are because of SLE flare or something else. The SLE flare is usually associated with high CRP, C-reactive protein. Serum procalcitonin is usually low, and delta neutrophil index is another marker, biomarkers which is talked about, could support the diagnosis of lupus flare, but none of them are very sensitive or specific. Delta neutrophil index, which reflects the fraction of peripheral blood immature granulocyte, is said to differentiate the SLE flare from infection, and that is a shift to the left of the WBC, that is immature cells, if it is there, suggests that this could be a factor to make a diagnosis of infection rather than SLE. And in a study, it was found that this delta neutrophil index more than 2.8 had a sensitivity of 54%, 88% specificity to diagnose infection in presence of fever with SLE. But this is still a test which is not been validated in different studies, and we need to wait before we decide to utilize this test. So, despite encouraging preliminary results, this delta neutrophil index as a biomarker requires further standardization and validation before they are introduced in daily clinical practice. The commonest biomarker that we utilize to make a diagnosis of flare is to check the serum autoantibody, that is double-stranded DNA, whose levels usually correlate with lupus activity, particularly the kidney activity. It is found that approximately 50% of SLE patients with kidney disease will have a high titer of double-stranded DNA. Complement C3 and C4 also has been utilized to make a diagnosis of disease activity. It has been said that serum C3 is more sensitive than serum C4, and we utilize both to make a diagnosis of disease activity. There are various other biomarkers which have been utilized to look at the disease activity, and the traditional biomarker that we talked about, the anti-double-strand DNA, low C3 and C4, are used commonly because it is commonly available. But the emerging biomarkers that are emerging is the ALCAM, is the activated leukocyte cell adhesion molecule, is said to be very, very useful, but still it requires more validation in the different trials before it becomes available. The clinical types of kidney flare or renal flare that we talk as a nephrologist are two types. One is the proteinuria flare, and the other is the nephritic flare. In controlled trials of lupus nephritis, it has been seen that 50% of patients who have responded to earlier immunosuppression, in the follow-up, one or more relapses will happen. Majority of them being a proteinuria relapse, and the remaining 20 to 30% will be a nephritic relapse. That means the kidney function changes along with the proteinuria. Occasionally, in the follow-up, we have seen that patients can switch the class from the class 4, which is a kind of diffuse proliferative glomerulonephritis, to class 5, which is a membranous glomerulonephritis. So we can have different kinds of flares in the follow-up. The definition of renal flare is based on the proteinuria increase, or the increase in hematuria, or change in the serum creatinine. When you have a serum creatinine change less than 30%, it is said to be a stable kidney function, and proteinuria increase more than 2 grams is said to be a kind of proteinuric flare. RBC increase of more than 10 is said to be a nephritic flare, and when you get cast, we talked about, is as a kind of nephritic flare. So nephritic flare is basically a kind of increase in hematuria, less increase in proteinuria, increase in creatinine, and presence of cast. So nephritic flare has got more sinister kind of prognosis compared to proteinuric flare. Commonest type of lupus flare in the kidney context is proteinuric flare. It has been noted that in patients who have class 4 or class 5 lupus nephritis, which is the commonest type of histological change in lupus nephritis, if they are followed for 3 years, and if they have more than 30% of the time in the zone of renal flare in the form of either hematuria, proteinuria, or renal dysfunction, there is increased risk of chronic kidney disease in the follow-up. That is, out of 3 years, if 1 year is the person continues to be in the proteinuric flare or the nephritic flare, chances of it going into chronic kidney disease is high. This is a patient still in my follow-up, disease of SLE for last 10 years with facial rash, malar rash, and first kidney biopsy showing a kind of classical class 5 lupus nephritis, that is, it is showing a membranous thickening of the glomerulus, has came after 10 years with increased disease activity during the COVID times, and from a creatinine of 1, it was creatinine of 5. What we see in the kidney biopsy, the glomerulus is squeezed by crescent, and this was a patient who was having a kind of rapidly progressive glomerulonephritis and was treated with higher immunosuppression and with the reversal of kidney dysfunction from creatinine 5 to 1.5. It didn't become normal, but patient is still in remission with the therapy that we gave. So the class switch was there. From class 5, it became class 4. This is a patient seen a year back, was planning pregnancy and went to a gynecologist who suggested the patient to stop MMF. The patient was on steroid as well as MMF. So steroid was reduced and MMF was stopped. And 2 months later, patient came with severe breathlessness and with fever and was getting evaluated for tuberculosis. What we see in the X-ray chest is a kind of classical cardiomegaly, where the top half is showing a kind of thin this heart, small kind of base with a widened kind of lower part of the heart, which is pitcher-shaped heart, which is said to be sensitive of pericardial effusion. What we see in the CT scan also is a large amount of fluid collection around the heart, and this was a patient who presented with cardiac tamponade, with breathlessness, with fever, and kidney function, which was normal, was showing an abnormality from creatinine 0.9 to 2 with hematuria and proteinuria. So the difficulty of deciding at that point of time was, is it a tuberculosis, or is it some other infection, or is it a disease activity? Patient was treated on the lines of disease activity, and patient improved and is having a kidney function in the slightly abnormal range. Creatinine is around 1.3, which is not normal for the patient, but that happened because the drugs were discontinued. Because we have talked about what is the cause of lupus flare, and one of them is certain drug stoppage for whatever reasons. So the NICE guideline has given a very nice kind of summary of what to do when we see a patient of mild activity, moderate activity, or severe activity. Mild activity is just a kind of constitutional symptoms of fatigue, malar rash, where we can give small doses of prednisolone, less than 20 milligram, and along with hydroxychloroquine. Other NSAID can be also prescribed, but we need to quickly reduce the prednisolone to less than 7.5 milligram of the disease is controlled. Moderate activity, for example, a patient who has pericarditis, pleurisy, they may require higher dose of steroid. And when the patient has a severe activity, like the patient that we showed who has discontinued drug, the drug of choice could be higher dose of prednisolone along with other drugs as is appropriate. So this just to give an example, what do we mean by mild SLE flare? These are the two patients who are having a malar rash on the face, other having discoid rash, that is disc-like lesion on the face. They will require a local topical steroid with oral steroid in low dose, less than 20 milligram, along with hydroxychloroquine. So a person who has skin rash, mouth ulcer, mild arthritis, or muscle weakness can be treated that way. This is a patient of SLE presenting with in the follow-up with severe breathlessness, and what we see is a kind of large amount of pericardial effusion, pleural effusion, which was tapped, and what we see in the pleural fluid, presence of LE cell. So typical of lupus activity. This patient will require a steroid dose in a higher dose of 1 milligram per kg to control the lupus serositis. Here is a patient who was an SLE lupus nephritis in the follow-up and came with Raynaud's phenomenon with tip gangrene. And what we see in the X-ray of the joint, that there's a kind of calcification in the muscle plane. This patient was having dermatomyositis-like manifestation in addition to SLE with calcification. This is a disease of moderate activity, and it will require increased increment in steroid dose along with addition of either MMF or cyclophosphamide. This patient was treated about 20 years back with cyclophosphamide to control this disease activity with good kind of result. That this was the histological picture of that patient who was having a Raynaud's phenomenon, the tip, etc., classical kind of BPGA with a granular kind of deposits of IgG class. Class 4 lupus nephritis is the commonest type of histological lesion in most of the patients of lupus nephritis. Here is a patient who had an undiagnosed SLE, underwent pregnancy, and postpartum patient came with severe breathlessness to cardiology department. What we see, and with a diagnosis of pneumonia, what we see in the X-ray is a kind of triangular kind of opacity, which is considered thought as pneumonia, but was found on subsequent evaluation to be a pulmonary infarct. Patient was evaluated by different images. What we see in the CT scan, which was done about 30 years back, a kind of opacity in the lung corresponding to the X-ray chest, which was a kind of pulmonary infarct. Patient had a APLA syndrome, a high levels of antiphospholipid antibody was there, and this is the CT scan of the abdomen. Which what we see in the scan is that the IVC is showing a kind of filling defect, which was a clot in the IVC. Right kidney is not showing any contrast secretion, but left kidney was showing contrast. So it was a patient who was having SLE with IVC thrombus, renal infarct, and pulmonary thromboembolism, presenting first time postpartum as a lupus flare, where we found that C3, C4, and double-strand DNA was highly positive. So this could be one presentation of a lupus flare, which is a life-threatening situation where we have to treat with intensified immunosuppression along with kind of anticoagulants, which was given in this patient. So the treatment of SLE as well as lupus flare will depend on the degree of activity. The mild activity like arthralgia, low-grade joint pain, minor skin rash, fatigue is treated by usually with hydroxychloroquine, NSAID if renal function is normal, and local steroids. Moderate activity like arthritis, pleuritis, pericarditis, or platelet count above 25 to 50,000 is usually treated with steroids, 20 to 40 milligram, and slowly reduced along with other drugs like azathioprine, methotrexate, or sometimes rituximab. The severe SLE, which is really organ dysfunction like nephritis that we have seen on few patients, a platelet count below 25,000 is treated with first steroid with or without with a follow-up oral steroid and mycophenolate with or without belimumab. So there are many drugs which are given based on the disease activity, based on the local expertise. So what is shown in the slide is that drugs which are used for treating SLE are methotrexate, azathioprine, leflunomide, mycophenolate, mofetil, cyclophosphamide, tacrolimus, cyclosporine, rituximab, belimumab. All these drugs can be used in appropriate situation. The newer drugs which are now being talked about in the context of lupus nephritis are voclosporin and the CAR therapy, which is a therapy which was earlier started in the malignancy to treat various kinds of cancers, but now it is also being applied in a kind of refractory situation of lupus. When we talk about treating, we need to also remember when to stop the immunosuppression. The optimum immunosuppressive drug therapy and tapering is crucial for reducing the risk of SLE flare. A large observational study in the Toronto Lupus Clinic showed that absence of serological activity, that is ANA, double-strand DNA, are on low titers. Along with when we have patient is having this low or serological activity, gradual tapering by 25% immunosuppression over months predict lesser risk of relapse, or very relapse-free drug withdrawal is possible. Although the optimal duration of therapy is still not settled, it is said that people who have no organ dysfunction and disease is looking serologically quiet, minimum 2 to 3 years is required. But those who have organ dysfunction like lupus nephritis, one should have a disease quiescence for more than 5 to 7 years as per the various reports. So in this context, one of the trials, the risk factor for flare in patients with systemic lupus erythematosus after glucocorticoid withdrawal had the systemic review and meta-analysis showed what are the things which can influence the glucocorticoid withdrawal and flare. So it was in this the meta-analysis what was seen that younger female, younger age female, that is age less young, as well as serologically active but clinically quiescent. That person has a positive kind of ANA, double-strand DNA in high titers or complement low, but clinically quiescent. These are the patients who are at high risk of lupus flare, the drugs are stopped. So what they concluded in this meta-analysis that younger age and surgically quiescent patients are potential risk factor for SLE flare among patients who discontinue GC, and such patient probably low dose immunosuppression is advocated. Hydroxychloroquine might prevent flare among these patients, and it should be a part of every therapy of SLE. A trend of lower risk flare was found in patients with older age or patients who were taking hydroxychloroquine, although statistical significance not reached. Concomitant use of immunosuppression one was not associated with reducing the risk of flare. That is, if they were on some immunosuppression, still it didn't reduce the risk of flare if they were not getting hydroxychloroquine or they were younger. So there are many factors which can influence flare, and in young people, particularly with surgical activity, even if there are no clinical signs, we need to maintain them on low dose therapy for a longer time. The management of in the context of management of lupus flare, it has been mentioned that it is not recommended that we should escalate the treatment in clinically quiescent but surgically active lupus. But since this strategy carries the risk of over-treating the patient with glucocorticoid, so that means patients who are having a kind of lab report suggesting of lupus activity, they need to be continuous on a kind of maintenance dose of immunosuppression rather than increasing the dose to prevent the risk of exacerbation. So these patients should be monitored for early identification of objective signs of disease exacerbation, was the message from that publication. Maintain nephritis trial, which was an important trial to decide what is the best kind of therapy for maintenance in long-term immunosuppression, where azathioprine with bipolar mofetil were compared. So what was found that both the drugs over 10 years of follow-up had a similar kind of result. That is, maintenance treatment with azathioprine was as efficacious as MMF in preventing renal flares and developmental end-stage renal disease over a period of 10 years. And they suggested that you can use the drugs as you feel based on the patient economics. Optimum immunosuppression, drug tapering and withdrawal is still crucial for reducing the risk of SLE flare-ups, was the conclusion in this publication. Discontinuation of switching from mycophenolate to less potent agent like azathioprine or CNI earlier than 2 years after attaining renal response carries a twofold increased risk of subsequent flare. So patients who are having renal disease, it is better to continue the drug for at least 2 years before you try to switch from MMF to azathioprine, was the message. The optimal duration of maintenance therapy in SLE has still not been established, and it is recommended that for patients who are having kidney disease, 5 to 7 years of remission is required before we can think about discontinuing a drug, as opposed to 2 to 3 years for milder kind of disease. When and how to discontinue is also an important point, and it was in the Toronto Lupus study, it said that those who are having inactive disease, 25% reduction, and then keep on following what is happening to decide when to stop the drug. Likewise, longer duration of immunosuppressive treatment and renal response both correlate with higher odds for successful drug withdrawal patients with lupus nephritis. That is, patients who are received for longer treatment, they are likely to be successful in being withdrawn of the drugs after 5 to 7 years, as in the case of kidney disease. So the key takeaways from my presentation is that despite advances in the treatment, a significant proportion of SLE patients manifest with one or more disease exacerbation, which can incur significant burden in financial as well as impact adversely the long-term outcome. The risk is particularly higher in the context of continuous, uncontrolled surgical and clinical disease activity, especially from major organs and young person. Apart from targeting low disease activity or remission, physicians looking for SLE should be aware about the strategies for preventing disease exacerbation, particularly maintaining an effective immunosuppression and biological therapy at a well-tolerated dose for adequate time period. For future, we are waiting for the other biomarkers which can predict the flare with higher accuracy than the conventional biomarker that we use to make a diagnosis of flare. That is all that I wish to talk about in the context of lupus flare. Thank you. Any questions are welcome.
Thank you so much, sir, for your wonderful presentation. So we do have some question if you like to take that up.
Yes.
Yes, sir. So, sir, the first question from our audience is, what are the current guidelines for managing lupus flare and how do they differ from maintenance therapy?
The current guidelines for lupus flare revolves around the same concept that we need to categorize the patient into categories of mild, moderate, and severe. Mild kind of increment in the disease activity will require a kind of milder kind of increase in the immunosuppressive regimen. That is, person who is say on a small dose of this steroid, like say 5 milligrams, and they can increase to 20 milligrams for the cutaneous flare, and then it can be reduced. Moderate flare will require a higher immunosuppression, that is 0.5 to 1 milligram per kg of steroid, along with addition of uh, MMF or addition of azathioprine for disease activity control. While the severe flare will mean that we're trying to treat with high dose steroid along with second line drug like MMF or third line drug like rituximab or IV methylprednisolone, depending on the clinical context. So the treatment guidelines suggest that we need to categorize the patient into a zone of mild, moderate, and severe based on the indices that we talked about, the SLED, SLE, disease activity index, or BILAG scoring, or physician global assessment, or a clinical judgment to decide what kind of drug intensification is required.
Thank you, sir. The next question from our audience is: how do you monitor a patient with lupus for signs of an impending flare?
Uh, it is said that we try to monitor the patient by the clinical assessment. The clinical assessment means that we know that whenever a flare happens, 75% of the time the flare happens in the same zone. That if a person has a kidney disease, the flare is likely to affect the kidney as a first organ, but though it can happen in the other domains also. So we try to look at the patient's labs, particularly the presence of kidney dysfunction, the urea, creatinine, proteinuria. You see urine examination for hematuria, and lab report of checking the ANA, double strand DNA, C3, C4 as is appropriate. We do not try to do a routine check of all these things unless there are reasons to check in that direction. The routine checks are basically a urine examination and creatinine in the patient of lupus nephritis. In other situations, the clinical examination is enough, like patient who has a cutaneous kind of disease with a malar rash, the skin rash is settling down or not, that will give an idea whether they need to investigate with other kind of lab reports. The labs which are said to be suggestive of lupus flare are at the moment which are available are basically checking the titers of ANA, double strand DNA, CT and C4. The other biomarkers are not very specific or sensitive to pick up a diagnosis like the CRP that we talked about, or the other thing like procalcitonin. Those markers are basically done to exclude the possibility of infection, because when a person is on these therapies, the fever could be a manifestation of disease activity as well as fever could be a manifestation of infection. So those markers are done to segregate whether the symptoms that you are seeing, which are part of SLE, as is already known in different domains, is because of any other disease or the same disease.
Thank you so much, sir. The last question from our audience is: are there any specific lifestyle modification or self management strategies that can help prevent lupus flares?
Yes, this is a very important kind of point, because it has been noted that this SLE flare can be self-inflicted. That is, if you are getting exposed to direct sunlight without using a kind of sunscreen, or without using umbrella, or going to a beach, that could be one thing which can be avoided. Second thing is that it has been seen that any kind of stresses, particularly not sleeping well or any other kind of stress, can lead to a disease activation. So one has to have a kind of sleeping on time. That is easy thing to do, etc. And third thing that is there, to avoid hormonal therapies when you are having SLE without asking the doctor. Like for example, this is a disease commonly of females. 9:1 is the ratio of female to male, etc. So the menstrual irregularities, which can be a part of disease versus it could be incidental if person takes on his own the oral contraceptive pills or any other kind of hormonal pills, which can lead to a disease activation, like the case that I showed where patient was prescribed the drug and patient had a relapse. So ultraviolet ray exposure prevention, and for the same we need to give vitamin D supplementation, because vitamin D has been found to be linked to disease activity. If person has vitamin D deficiency, that is said to have increased of disease activity. So we tell them not to get exposed directly with sunlight, use umbrella, use the kind of sunscreen, but take a vitamin D. Regularizing the meal plan, sleeping plan, avoiding stress, taking one day off from the work in case they are working, and avoiding drugs on their own, particularly the hormonal therapies. And probably these are the, and then not to discontinue the drug, because many times people discontinue the drug because of cosmetic reasons. Because when you're giving steroid, it can produce moon faces, and people being sensitive to their looks may discontinue the drug based on somebody else's suggestion that this drug is producing side effects, stop the drug. So drug discontinuation is said to be one of the very important factors for disease reactivation, and that has to be always told to the patient.
Thank you so much, sir, for answering all our questions. Before concluding today's session, sir, any last remarks from you?
Uh, SLE is a disease which affects mostly young females. This is a disease which doesn't produce infertility, though it can produce increased risk of abortions. It should be treated in consultation with various specialists who are trained to look at it and who are interested to treat it. The drug is a long therapy. People may get disappointed that the disease is not getting cured, but with the availability of so many drugs and so many kind of tests which are available, we can have a good quality life. The patient follows a kind of clear-cut scientific pattern. So this disease is controllable. It doesn't impair with fertility, because that is a thing that most of the females who develop SLE go through, because they have to go through the mother-in-law syndrome, because they many times they try to hide the disease, and when they get pregnant and they stop the drug, they get the disease activity. So it requires the kind of counseling, not only of the patient, the family, but maybe the other family members who may be important in dealing with this situation.
Thank you so much, sir, for joining us today. And with your permission, I would like to conclude today's session. Thank you.
Thank